Good afternoon. We will be beginning in 1 minute. So please take your seats and maybe call your friends, if there are any remaining. Okay. Well, time flies. It's 10:45. We will be beginning. My name is Suhail Hussain. I'm from Stanford University. It's a privilege to address this group. I'm joined by Dr. Sundaram Ramakrishnan, who's a professor at the University of Miami. And this session for this 1 hour is on COVID. And of course, it's a topic of the hour of the last 18 months and perhaps the next couple of years. So I'm sure you're going to find this of interest. Each of the speakers will be providing their perspective as well as their research on topics related to acute pancreatitis primarily. And with that, I also wanted to just make a note. We learned a few things over these last 3 days, and maybe I might summarize what might work well. Each of the presenters will be held to about 14 minutes maximum, and that should allow for questions at the very end. So please save up your questions. You can also put them in the Attendify chat. It stays on the chat for 3 months, and the presenters can answer your questions or others can comment on them. There is an option for those who are on the Zoom to put in the Zoom chat. I would recommend the Attendify comment over the Zoom, but if you so choose the Zoom, we have a couple of members who will be looking at the Zoom chat and they may repeat your questions so that everyone's questions are taken into account. I think otherwise, we will just have a traditional format of questions. And with that, I'd like to introduce the first speaker, who is Dr. Vijay Singh from the Mayo Clinic in Arizona, professor of medicine and gastroenterology. You've heard from Vijay on several occasions today and over this meeting. I think I'd call him, coming from Silicon Valley, the Steve Jobs of the exocrine world, in that he is sort of one who shakes up dogma, turns it upside down, including in the lipid field. So it's a pleasure to hear from Vijay at this session.
So Hale, thank you so much for the very kind introduction. We will be talking on how ignoring the exocrine pancreas increased deaths from COVID-19. You have seen my previous disclosures. They remain the same, so I'll omit that slide for now. We'll just go for the mechanistic clues. 10 years ago, we published that fat may worsen pancreatitis, that fat surrounding the pancreas or within the pancreas in obesity may get hydrolyzed into fatty acids, and the unsaturated fatty acids so formed may then worsen the injury in pancreatitis. The message hasn't changed much. It is essentially the same message. It's just that we know the mechanisms a little better. For example, we now know that what we eat is what we accumulate. You saw that slide yesterday. If it's unsaturated fatty acids, we accumulate that. We now know that the unsaturated triglyceride fits better into the lipase pocket than the saturated triglyceride, where the saturated blue chain pushes the triglyceride out of the lipase pocket and makes it less hydrolyzable. The release of unsaturated fatty acids, thereby shown in these V's, which I cannot reach, which are unsaturated fatty acids, are more aquastable and cause more systemic injury. And we'll see how this may be relevant to COVID-19. This is a meta-analysis published last year in gastroenterology, which shows that patients with lipase elevation and COVID-19 infection had more severe COVID-19. The odds ratio went up significantly over here. You can see about a little more than threefold. There are other similarities that pancreatitis and COVID-19 share. For example, every COVID-19 is not severe. In fact, this is an old slide, but out of 1,000 cases, about 50 to 60% may be asymptomatic. Most of them end up being mild, self-limited. And then about 10 to 20% may become severe. And a significant proportion of them may die. And you will see the epidemiology of this over the last year and a half. All of us have looked at worldometers, I believe, and you'll see the data from worldometers as what we learned from there. And the other thing is that obesity is a modifier for COVID-19 too. Patients who are obese and have COVID-19 have worse outcomes. It's well known. So both pancreatitis and COVID-19 are acute diseases. Both are severe in about 10 to 30% of cases. Both are worsened by obesity. Both have multisystem organs failure when they are severe. Both have the cytokine storm. And the closest direct evidence linking COVID-19 and pancreatitis lies in the autopsy data. Patients who died from COVID-19 and had full body autopsies, not just lungs, abdominal included. There are two studies on that. One in Lancet Microbe, the other in Annals of Internal Medicine. 30 to 40%, it's small numbers, but what we can gain from here had pancreatitis or fat necrosis. Most of the times this was not diagnosed ante-mortem. So the clues, when the pandemic was starting, that's when we did our first studies. As to the epidemiology, we were looking at the numbers on worldometers or the Johns Hopkins database every day, and you'd see the numbers going up for different countries, what was happening. And the pattern seemed a little disconcerting, and the pattern seems very similar to what we would see in pancreatitis based on our hypothesis and the dietary patterns of the countries that we were getting on that. For example, so we started compiling a database. Every day, we would look at the mortality of a country, and we would see, and this is for every country with more than 1,000 patients that were being declared. And then we would compile other parameters for every country, including dietary parameters, and then hospital resources, how many ICU beds they had, what the demographics, of the country was, what the latitude of the country was, and this was compiled. And what we saw was that countries with as we know them, with a more high in saturated fat consumption, Italy, Spain, China, had higher mortalities than countries with more saturated fat diets. I knew this by experience because that's what I had been working for the last few years in pancreatitis. And now if we zoom into this a little bit more on the full-time scale from the beginning of the pandemic till now, you can see that the steepest slope in mortality was at the beginning. Nowhere again has that slope been replicated. It was in the beginning of the pandemic, and even though the number of cases was low, mortality was the steepest at that time. Because that was the time, and this is the time which we studied, those 14 days was the time when there was no social distancing, there were no medicines, there was no dexamethasone, no remdesivir. And on the television, we could hear every day, we are running short of ventilators. We don't have ventilators for our patients. So that was the time when COVID-19 was really bringing out its true colors without human intervention. And at that time, we took all these parameters and did initially a univariate analysis and then a multivariate analysis. On the top are the COVID parameters, about how many cases there were. These are the resources in the country, how many hospital beds they had. These are the economic resources of a country, which are per capita GDP, etc. For every day, this was collected. And that's all we had at that time in the public domain. And what we found was the unsaturated fat consumption of a country based on the Food and Agricultural Organization database was the only thing that stood out on multivariate analysis to be associated with mortality. And this is the graph that we see here. And these are the marginal plots taking every day's data for 14 days, so that it's not just biased by one day, but every day's data for 14 days, where we see that unsaturated fatty acid consumption was associated with higher mortality. Now let's fast forward to present. This was a poster you saw yesterday. And this is COVID-19 patients admitted to our ICU at Scottsdale. And it shows, yes, they are obese. And these are non-COVID patients admitted. Yes, they have a higher lipase. Yes, they have hypoalbuminemia. Yes, they have hypocalcemia. And yes, they have lower ionized calcium, very similar to what we see in patients who are developing severe pancreatitis, hypoalbuminemia, hypocalcemia, lipase elevation. This was a retrospective study that I showed yesterday too. And again, we see hypoalbuminemia, hypocalcemia develop in patients who are non-survivors. Very similar pattern to what we see in COVID-19. And we alluded to this yesterday. And this slide shows that what we'll see in fatty acids, linoleic acid has a very strong reaction with albumin calcium, explaining the hypocalcemia. Well, we were seeing these patterns and we said, we know that UFAs cause bad outcomes, but is the pattern the same? Do we see the same kind of bad stuff? Patients with severe COVID-19, the only fatty acid, long chain fatty acids, and these form about 98% of the fatty acids in our circulation. The only one elevated was C18-2 and its product, C24, linoleic acid, arachidonic acid. And yes, they had higher overall percentage unsaturated fatty acids and unbound fatty acids, which because of the double bonds, they can exist unbound. When we gave mice linoleic acid, we found the same pattern. We triggered the same cytokine storm in mice as the patients had. GRO alpha, IL-1 beta, IL-6, MCP1, TNF alpha, same pattern. You could trigger off with just giving LA to mice. So what we have seen so far is if there's this is all associational data, no causality so far. All we've seen is that if you have lipase elevation, there's an increased risk of severe disease. In COVID-19 patients in the ICU, we have higher unsaturated fatty acids. These can cause hypocalcemia, and these can be unbound to albumin when there's so much release that exceeds the albumin binding capacity. Now, on a more mechanistic level, there is organ failure. So endothelial damages has to take place. So if you take an endothelial cell line, HUVEC-EC, and put a fluorescent LA, we find that the LA targets to the mitochondria. JC1 is a mitochondrial marker, and essentially targets to the depolarized mitochondria. And this is the dose response of depolarization. At 2.5 micromolars of unbound LA, we can depolarize mitochondria of endothelial cells. We can also functionally impair them. We can cause a drop in transendothelial resistance with LA. We can increase macromolecular permeability with 10 kilodalton dextran across the monolayer with linoleic acid. This is only not restricted to endothelial cells. Kidney cells have the same thing. And the reason this is relevant is what we see over here as bad outcomes in patients, basically organ failure or ECMO requirements, thrombosis, can be replicated in mice given LA. So as you can see here, VUN elevation, hypothermia, shock, and lung injury, tunnel positive cells in the blood vessels of the lungs and thrombi in the lungs, and renal tubular injury with these large lumina can be replicated in COVID in LA given mice. And this is very similar to what we has been seen in autopsies of patients with COVID-19. Tunnels in the lungs of patients show endothelial injury. And what we also note is the thrombi that they note in the lungs can be simulated by LA. Same thing is noted in terms of the tubular injury. In AKI or acute kidney injury stage 3, there are large tubular lumina, which we also see over here. The same pathology is replicated. DAMPs are released. Here you can see, you see in E-selectin going up in COVID-19. You see other DAMPs being ICAM1, dsDNA, and all being released into the circulation. And this schematic here summarizes the data very well as to how those cause organ failure. So mitochondrial injury resulting in endothelial injury, resulting in vascular leak, kidney injury. And if we put it all together, then the two parts clearly describe the pathophysiology that may be taking place. That fatty acid release causes the multisystem organ failure, DAMP release, and thrombosis in the disease. Let's go to the last couple of slides, and those are the therapeutic clues. So in the beginning of COVID-19, there was a lot of talk about famotidine. Famotidine seemed to improve outcomes. And if we go to any Walgreens or common CVS store and look at famotidine, you will find that famotidine mostly is available in these red cap, very attractive bottles. And if you look carefully what these are, this is Pepcid Complete. And Pepcid Complete is famotidine plus calcium carbonate. More calcium carbonate than famotidine. And what we can see here basically is that in those initial studies that showed famotidine to have benefit, most of them came in the outpatient setting. Whether it was this gut paper that was patients given high dose famotidine, perhaps they were taking famotidine plus Tums. And these are all studies from the US, where over-the-counter famotidine is available with calcium. The most revealing study actually was this one published in Gastro, where they say that the famotidine used in the hospital was in patients who were taking famotidine at home. It was a continuation, it was an assumption of home use of famotidine. So very likely that there was calcium being used there. But now if you look at the data in inpatient trials where it was only famotidine given to patients and studies outside the US, so no calcium there likely, there is no benefit of famotidine in those things. The lower paper in fact was published this month in Gut. And you see that famotidine alone did nothing. In fact, there were worse outcomes with famotidine in these patients. So to summarize, what have we learned? We have learned that both pancreatitis, so the clues that link pancreatitis and COVID-19 are, well, the clinical spectrum is varied. It is not that all COVID-19 is severe. It is a subgroup which gets severe. It's the obese subgroup that gets severe. We've learned that autopsies in COVID-19 do have pancreatic and fat involvement. There are unsaturated fatty elevations in COVID-19 and pancreatitis. There's early hypocalcemia, hyperalbuminemia, like Ranson's and Glasgow criteria in COVID-19. Acute low calcium and no albumin can only be induced by unsaturated fatty acids. No vitamin D can cause, there's no acute rickets or acute hypocalcemia that develops in vitamin D deficient people. It's a chronic disease if it's rickets or osteomalacia. Both have a cytokine storm, damp release, and thrombosis. And outpatient famotidine, which is very likely. And if you actually look at the sales of the companies, it's Pepcid Complete sells more than Pepcid alone. Outpatient famotidine, which is likely to contain calcium carbonate, initially showed benefit in COVID-19, though it was not replicated in trials where famotidine alone was used. Thank you so much for the opportunity to present.
Right. It's my pleasure to introduce the next speaker. This talk is going to be virtual. Dr. Martin Freeman. He's a professor of medicine and gastroenterologist at the University of Minnesota. Martin is going to talk to you, and he is not new to this body of investigators. He's past president of APA and has received many awards as well. And the title of his talk is COVID and Acute Pancreatitis. Martin Freeman.
Well, hello, and thanks for being with us on this last day of the APA. I have no financial conflicts of interest, but my one major conflict is that I'm really not an expert on this topic. And I'll try to take you through what I've learned for this presentation. Some of the real experts on this topic are my colleagues, Dr. Ahmed Dirwesh, Dr. Stuart Amato, who published this early observation in gastroenterology just last year, which of course is infancy of the epidemic in our understanding of it. A reflection of how little we know and how early we are in our understanding of this epidemic and its effects on the pancreas is the fact that my PubMed search fits onto one slide. The two earliest observations were published last year in gastroenterology, for which, as we know, Ashok Saluja is the section editor related to pancreas. And the first is from my colleagues at the University of Minnesota, Dr. Deerwesh, Trichodenathan, Mallory, myself, and Dr. Amato. But the work here was initiated and carried out by Dr. Deerwesh and Amato. The second is a similar observation comparing hospitalized patients with acute pancreatitis with and without COVID from a multi-center consortium. Now, the first study by Dr. Deerwesh and colleagues basically compared all the patients within our single healthcare system in the Twin Cities of Minneapolis, St. Paul, presenting with acute pancreatitis and looking at those who were PCR positive for COVID versus those that were PCR negative, and adjusted for indices of severity, etiology, etc. And the standout findings were that patients who were PCR positive for COVID had substantially less alcohol as etiology, which somewhat surprised me, to be honest, and substantially more idiopathic pancreatitis. And when comparing indices of severity, had substantially more organ failure, multi-organ failure, and persistent organ failure. These observations suggest somewhat that the higher prevalence of idiopathic etiology might indicate a causal role, or at least an exacerbating role, of COVID and pancreatitis. The second study, which is very similar design, but a multi-center consortium, published subsequently in gastroenterology, showed that, again, the prevalence of idiopathic pancreatitis was much higher in the COVID group, although they did not find differences in severity. But together, we could say that patients with COVID-19 had a worse outcome, at least in one study, and this was despite less alcohol and more idiopathic. These are just observations. Another clinical observation, which is currently being submitted for publication from my colleagues, is that in long-term follow-up of that cohort of patients, substantially more patients with COVID positivity in pancreatitis developed pre-diabetes or new onset diabetes mellitus over a 3 to 6 month follow-up period, compared with only 2% of those either with isolated acute pancreatitis or COVID-19 alone. Now, a really nice review by Dr. Samanta and colleagues from Chandigarh, India, and Rishikesh, India, showed that there's a burgeoning understanding of how COVID might affect the pancreas, and summarized nicely the available data at the time. They postulated that pancreatic injury, exocrine and endocrine, is really multifactorial. There could be direct virus-mediated injury to acinar ductal and islet cells via ACE2 receptors. SIRS, which of course is a hallmark of COVID infection in severe cases, may result in pancreatic injury on its own. And finally, damage by pro-inflammatory milieu that is prompted by COVID infection due to a whole number of mediators of inflammation and immune dysregulation, virus-induced lipotoxicity, and perhaps even from the drugs used to treat severe COVID infection. This is their schematic, which shows that the coronavirus is transmitted to humans via the aerosol droplet or perhaps fecal-oral route, then to the respiratory tract, GI tract, then the bloodstream, then to the pancreas, and then the spike proteins on the SARS-CoV-2 virus bind to the angiotensin 2 receptors on various types of pancreas cells, including ductal, acinar, and beta cells. More direct support for this hypothesis is supported by a really nice paper in JCI Insight, recently published, that using single cell RNA sequencing and immunolocalization techniques, that ACE2 was expressed in pancreatic islet, ductal, and endothelial cells in non-human primates and in humans. And in the experimental model and in autopsies showed that this could account for new onset diabetes and suggest that thrombofibrosis found histopathologically in those sets may promote acute and chronic pancreatitis and potentially lead to new onset diabetes. So we have a kind of insight into what may be happening at the cellular level. And again, not my area of expertise, but as an overview of clinical pancreatitis, this may be valuable. Now, it's hard to find any humor in the whole coronavirus issue on any level, but I think I may have found direct evidence last week in an individual patient. Now, we all know the much ballyhooed image of the coronavirus itself. And what I found last week was this image inside the pancreatic duct of a 17-year-old female with CFTR-related hereditary pancreatitis. And this is pancreatoscopy to perform electrohydraulic lithotripsy on her multiple pancreatic stones. And everybody in the room had the same observation. When asked, what does this look like? I think we all agree. So all joking, such as it's possible here aside, we're just at the infancy of discovering what new insults the coronavirus can add to injury of pancreatitis, or perhaps even cause. So to summarize, COVID-19 seems to cause pancreatitis very rarely, but it may lead to worse outcomes in those who are infected. And it does seem, even mechanistically as well as clinically, to increase risk of diabetes. And of course, more is yet to come on understanding of this pandemic. Thanks for your attention.
All right, we are moving to the last speaker. It's my distinct pleasure to introduce Dr. Pramod Garg, who is currently at All India Institute of Medical Sciences, incidentally, my alma mater as well. Dr. Garg is a professor of gastroenterology, and he's going to talk to us about COVID-19 and acute pancreatitis, a dual disease model. Dr. Garg.
Good morning, ladies and gentlemen. I would like to thank APA and its leadership, Dr. Joe Hines and Dr. Saluja, for having given me this opportunity to discuss today about acute pancreatitis and COVID-19, which we call as a dual disease model. We know that viruses may cause acute pancreatitis, for example, mumps, hepatitis, Coxsackie, and now SARS-CoV-2 has been added to the list. But unlike hepatotrophic viruses, for example, hepatitis A and hepatitis B, there is no known pancreatotrophic virus. In patients with SARS-CoV-2 infection, pancreas may get affected as a bystander. And we know that ACE2 receptors with which this virus binds to gain entry into the cell are present on beta cells, ductal cells, and also to some extent on SNR cells. And when such a patient develops acute pancreatitis, the clinical course of the disease gets complicated. Now, if you look at the relationship of acute pancreatitis and SARS-CoV-2, there are two ways of looking at it. One is that patients who have acute pancreatitis may develop secondary COVID-19 during the course of their illness. This may occur early on within the first 2 weeks or so, or this may occur later after 2 to 3 weeks. And this we call as co or superinfection or SARS-CoV-2 in patients who have acute pancreatitis. The second scenario is a patient presents with SARS-CoV-2 infection, he has COVID-19, and develops acute pancreatitis subsequently. Now, this is what we call as virus-induced or SARS-CoV-2 induced acute pancreatitis. Last year, we reported a small series of 3 patients who had severe acute pancreatitis, were hospitalized. They had persistent respiratory failure and were recovering from their illness. And then they developed at different time points a nosocomial COVID-19. This was during the first surge of SARS-CoV-2 infection in New Delhi. But none of them developed respiratory failure due to COVID-19, although they were recovering from acute pancreatitis-induced respiratory failure. And this suggested to us that both the illnesses may have different courses. And if both the diseases are present, one has to actually look at the severity of individual disease and understand how the disease course is complicated. 2 other series, a fairly large series of 32 and 149 patients were published last year. And early this year, both of these showed there was increased organ failure and mortality in patients who had both acute pancreatitis and COVID-19. A recent meta-analysis also showed that of about 88,000 patients with COVID-19, the pooled prevalence of acute pancreatitis was about 3.1%, and a mortality of 18.5%, which was fairly high. There are certain gaps in our knowledge. For example, these studies have not differentiated between SARS-CoV-2 induced acute pancreatitis and those with co or superinfection. The characteristics of SARS-CoV-2 induced acute pancreatitis are also not well known, and we don't know the outcomes depending on the timing of infection in patients who have acute pancreatitis. We therefore conducted a prospective study late last year and early this year with the objectives to characterize SARS-CoV-2 induced acute pancreatitis and to study the impact of such infection, either a co-infection or superinfection, in patients who have underlying acute pancreatitis on their outcomes. The study was conducted in 2 tertiary care hospitals. All consecutive patients with acute pancreatitis and SARS-CoV-2 infection were included, and outcomes of patients with SARS-CoV-2 induced acute pancreatitis, viral co and superinfection in such patients with the dual disease were studied. We included controls who were drawn from a prospectively maintained database of patients with acute pancreatitis prior to the pandemic in 1:4 ratio after propensity score matching. We defined SARS-CoV-2 infection-induced acute pancreatitis if a patient met all three criteria. That means he had RT-PCR confirmed SARS-CoV-2 infection. He developed acute pancreatitis within 7 days of onset of COVID-19, and all other known causes of acute pancreatitis were excluded. Co-infection of SARS-CoV-2 was defined if a patient with acute pancreatitis acquired the infection within 14 days of onset of known etiology, and superinfection was defined if such a patient acquired infection after 2 weeks of the onset of acute pancreatitis. The outcome measures were comparison of severity and in-hospital mortality of patients with acute pancreatitis, those who had associated COVID-19 or no COVID-19. The influence of timing of co and superinfection of the virus in terms of mortality and organ failure was also studied. We had a cohort of 85 patients studied prospectively, those who had this dual disease of acute pancreatitis and SARS-CoV-2 infection. 18 had SARS-CoV-2 induced acute pancreatitis, 23 had acute pancreatitis with SARS-CoV-2 co-infection, and 44 had acute pancreatitis with superinfection of the virus. And we also had 230 patients, matched patients with non-COVID acute pancreatitis. Now, if you look at the 18 patients who had SARS-CoV-2 induced acute pancreatitis, the severity of COVID-19 was mild in 8, 44%, moderate in 3, severe in 2, and critical in 5, 27%. And in these patients, when we looked at the severity of acute pancreatitis, 8 had mild acute pancreatitis, 6 had moderate because they had local complications later on, and 4 had severe acute pancreatitis because of organ dysfunction. Now, it may be often difficult to differentiate the organ failure, that is particularly respiratory failure, because of the virus or because of acute pancreatitis. Now, here is a representative chest X-ray and a CT scan of patients with acute pancreatitis, the upper panel. And if you see here, the lung fields are by and large okay. There is some effusion. On CT scan, we can see bilateral effusion, but the parenchyma is relatively preserved. On the other hand, in the lower panel is a patient with severe COVID-19. If you look at the chest X-ray, bilateral pneumonia is present, lung infiltrates massive, both on chest X-ray and a CT scan. And this is the best way to differentiate between COVID-19 induced respiratory failure and that due to acute pancreatitis. Of these 18 patients with SARS-CoV-2 induced acute pancreatitis, 11 had respiratory failure, 7 needed ventilation. Steroid was given in 7 of such patients who had virus-induced respiratory failure. 9 of these patients developed necrotizing pancreatitis, with 6 of them requiring intervention. The in-hospital mortality was 44% in them. 6 died due to critical COVID and 2 due to severe acute pancreatitis. The mortality was higher compared with a propensity matched cohort of 59 patients who had non-COVID acute pancreatitis. Mind you, if you look at the mortality here, 2 patients who had non-severe COVID-19 developed severe acute pancreatitis, and they died because of that. The outcomes in those patients who had SARS-CoV-2 co-infection or superinfection were also similar. If you look here, this is the group of patients who had COVID-induced acute pancreatitis, and of the 18 patients, 8 died, 6 due to COVID-related causes, 2 because of pancreatitis. In patients who had co-infection, of the 23 patients, again 8 patients died, but 5 due to COVID, severe COVID, and 3 due to severe acute pancreatitis. And of the 44 patients who had superinfection, they were having acute pancreatitis for quite some time. 12 of these patients died, again 8 due to severe COVID and 4 due to severe acute pancreatitis. And subsequently they developed infected necrosis. Now, if you look at the organ failure and mortality in the overall cohort of 85 patients, they had much higher organ failure and mortality compared to non-COVID acute pancreatitis patients. So in summary, ladies and gentlemen, I have presented to you that this is a dual disease model of acute pancreatitis and COVID-19. This is something that we have not seen earlier. SARS-CoV-2 may cause acute pancreatitis by itself, as some other studies have also shown. The organ failure and mortality was higher in such patients, largely attributable to the severity of COVID. We have also shown the difference between SARS-CoV-2 induced acute pancreatitis and those with co or superinfection, which may complicate the clinical trajectory of those having underlying acute pancreatitis. These data have implications for etiology of acute pancreatitis and call for surveillance, continued surveillance for such infections in patients with acute pancreatitis hospitalized during the ongoing pandemic. I would like to thank you for kind attention. I will be happy to take questions.
Thank you, Professor Garg, and Dr. Singh, please come up to the front. I'm going to just sit over here because I noticed that the Zoom chat comments were not attended to, and the only way to see them is to sit here. So please, Dr. Saluja.
Thank you. I want to start with appreciating both Dr. Freeman and Dr. Garg for joining us. Pramod and Marty, I wish you were here. I think there's no feeling like touching you and hugging you. And I really miss both of you so much. Same time, I'm so glad that Vijay is here with us to give a talk. But I hope that we'll see you both in very near future. Thank you. So I was watching a poster yesterday in the meeting, and where they were showing that incidence of acute pancreatitis in patients who are positive with COVID, whether they are hospitalized or not, or anyone who's positive with COVID, was lesser than non-COVID population. What's your experience on those things? Any one of those three, or all three of you can comment on that, because I was a little surprised. My thought is, and I still think that this more incidence. I mean, obviously there's more severity. The data is very clear, and what Vijay is showing, and then all of you have shown, is that if you combine whatever COVID is causing, the inflammation and everything, with pancreatitis, it will be severe. But is it true that we have less less pancreatitis in COVID positive population versus not? Marty?
I'll let Pramod answer the question. He had shown the data, I believe, that out of 88,000 patients, 183 had pancreatitis, 88,000 COVID patients. And I don't know the time scale over which this was done. So it was about 3% risk of pancreatitis that he showed in that new study. But to me, that seems more than what we have in the general population per year. But I'll leave that for him to answer in more detail. I'm not familiar with the paper.
Thank you, Dr. Saluja, and thank you very much for your kind words. I too wish that I were there with you all, maybe next year. So to answer that question, so this last study that I mentioned, published in Gut recently, showed 3% of people who were COVID-19 positive had acute pancreatitis. Now, to me also, this figure looks on the higher side, but I'm not sure. Yeah, but I'm not sure that the incidence of acute pancreatitis is lower in those with a COVID-19. That, to my mind, doesn't seem right. In fact, it should be higher.
Right. The presenter was yesterday. I asked him that what, and their thought was that maybe that because all the ERs and hospitals are full of COVID patients, and many people who have some abdominal pain or so-called pancreatitis symptoms, they just stayed home. They were scared to go to ER. So that may be one of the reasons that why there's less. So it's more of a counting error than real disease error.
Yeah, if you look at the epidemiology, lifetime risk, for example, of acute pancreatitis, or annual risk, it's maybe about 0.1% of the population per year is what we usually quoted as the risk for pancreatitis. So a simple way, let's say 300,000 pancreatitis and 300 million in the US. Simple way, 0.1% population. But that is over a year and a half out of 88,000, 3%, that's 30 times more. It seems that's pretty clear over there.
Thank you.
Okay, if I may, I have one question to all three of you. Recently, there has been a big hype in the papers, news media, that use of antidepressants like serotonin uptake inhibitors, like fluoxamine, is reducing the hospitalization of COVID patients as well as the severity. When I looked at the literature, fluoxamine has been shown to induce pancreatitis. There are several publications. I would like to all of you, either one of you, to comment on use of fluoxamine or antidepressant in COVID cases.
Great presentation to the panelists. Quick question for Dr. Garg. By the way, I'm from the University of Miami, Saluja Group. The question I wanted to ask you is it known really that, considering that a virus can exist in a lysogenic state or a lytic state, right? So how long, I know in your criteria, you had a patient that gets pancreatitis within 1 week or something like that, right? So is it known how long this particular virus can exist in the body before it can actually induce pancreatitis? Like, I just wanted to have your comments on that, if you know. Thank you.
So thank you. Great question. So let me just first take the other one about antidepressants, fluoxetine. So when we talk about drug-induced pancreatitis, I think it is more of hypersensitivity reaction or an allergic reaction that someone might develop a drug-induced acute pancreatitis. When you talk about a larger population, I think both animal data and now at least 3 studies have shown that this drug might be effective, but I'm not sure it will be used quite frequently now because we have 2 antivirals. One is now recently approved, the other is on its way. That's about the other. The other question about how long the virus may persist before it causes pancreatitis, I don't think anyone knows that. Our criteria are largely clinical, that once a patient is admitted primarily with SARS-CoV-2 induced disease with fever and sore throat and cough, and then subsequently develops acute abdominal pain with raised amylase and lipase, and you don't find any etiology. In the absence of a known etiology, we would ascribe it to the virus. And there has been quite an extensive experience earlier of virus-induced pancreatitis. Now, virus has been shown in the pancreas, within the pancreas, in autopsy studies, and the receptor has been shown. But to your question, I don't think we have answered that how long it persists before it causes pancreatitis. It does cause many other systemic disorders. And now it has been clearly shown that it causes disease in other organ systems. For example, we recently had a patient who had severe acute pancreatitis because of SARS-CoV-2 and also developed very severe myocarditis. So I think in some patients, it's a multi-system disorder.
Great, thank you. And just before we move to the live questioner, we do have one chat question, which comes from Paula Garrick, if I read it correctly. And the question is about comorbidities with COVID. And often the question is, what comorbidities increase the risk of developing COVID or severe COVID? And the questioner asks about type 1 diabetes and whether it is known to increase or affect the risk of COVID pancreatitis. If any of the questioners or presenters would like to tackle that.
We have looked at comorbidities in the retrospective cohort. I mentioned about 4,000 patients and their association with severe outcomes in COVID-19. We have not specifically looked at type 1 diabetes, but we've looked at diabetes in general. On multivariate analysis, it was not associated with worse outcomes in COVID-19, though advanced age, male sex, and obesity were associated with that. Again, their contribution in the odds ratio was much weaker than hypocalcemia or hypalbuminemia. That I'd like to make that very clear.
Thank you. And, that's exactly correct. Being male is more of a risk factor than some of these comorbidities. So it's a problem to be a male for many reasons.
Males are careless.
So please, and we have about 8 minutes or
Okay.
7 or 8 minutes. So we'll try to go rapidly. There are more questions.
Okay. Hi, I'm Anita, University of Miami. And I have a question to everybody in the panel. It's similar to the question that was like previous question that like the individual like asked online. My question is, individuals who, for example, they got COVID-19, but they don't have pancreatitis. So what are the factors that determine, for example, individual who got the COVID-19 to develop the pancreatitis later? And what are other factors, for example, that other individuals who have problems already with the pancreas, what are factors that causes that severity when they get the COVID-19?
We have specifically not looked at pancreatitis. What we have looked at is lipase elevation, because that's the way we looked at our data. The objective evidence for pancreatitis requires certain criteria, 2 out of 3 criteria to be met, which were not fulfilled in our group, but it was the lipase elevation and the downstream consequence of the substrate being present, so that means obesity, and thereby the product being present, that is what we found as linoleic acid being elevated in the sera of patients, and then the downstream consequences of the linoleic acid being all the organ failure thrombosis that we talked about. So what lipase this is? Frankly, lipase is a biochemical assay. It is not a proven one protein. There are 12 lipases we have. The assay is optimized to pancreatic ones, but other lipases that are released could also cause the same activity if they are in excess. So what we see from the obesity, lipase, fat involvement, fatty acid toxicity is not so engineered towards specifically pancreatitis, but more towards lipotoxic outcomes. I don't know if that answers your question, but I hope it clarifies our weakness from being specific to the pancreas.
Can I just add to that, when you talk about what predisposes patients to develop COVID-induced pancreatitis, I don't think we have enough data on that. But in those who already have acute pancreatitis, I think it is the prolonged hospitalization that puts them at risk of developing nosocomial SARS-CoV-2 infection. The other thing we have noticed is that not necessarily if someone has severe pancreatitis will have severe COVID, and the other way around. So the interrelationship is somewhat complex. Although someone who has severe disease, severe COVID and severe pancreatitis would obviously have a worse outcome. Thank you.
When you were doing the diagnosis of COVID, did you use a PCR assay on the feces for the determination? Is that the reason I'm going to mention something? I had an opportunity in early January to have a manuscript for a review for publication. About 15 scientists from the Wuhan Institute that were Chinese, and it looks like there were 2 embedded American scientists that were involved. And I was reviewing it from a statistical point of view. So I'm like Marty, I'm completely out of my league, but what impressed me there was they were trying to assess how to safely deal with nurses and everyone else in disposal of materials and cleaning of the restricted area. And the manuscript clearly indicated they had a PCR assay that was working for normal, for respiratory form, which they said was 59% of the 300 patients. And then there was 39% had GI involvement, no respiratory. and 19% had both. Now, in the whole thing, my problem was that I had a manuscript that never went anywhere, it appears. There's no report that it was being reviewed from any journal in the United States. And I didn't know what to do. It clearly said not to publish it. I have no control over it. So I didn't know who to send it to. But I do have a document that's with exhaustive information at the front end of explaining how the researchers were been protected from going into the restricted areas. They could only look through glass into the area of the patients. They didn't examine the patients. But the interesting thing was that they had a PCR assay for the feces. And I tried to make it available in the sense that there was no symptoms, they said, like fever and all the things that everybody was worrying about for the respiratory form did not occur with the GI. So when you're talking about the GI form, were you getting respiratory problems
Would you like to answer
along with it? They only indicate 19% would be both.
And maybe Vijay, can you keep your answer brief?
Yeah, we only tested the respiratory part. We didn't do any GI testing.
Okay, thank you. And Dr.
So I need
Purse,
guidance though. Should somebody from the GI group give, I have to get some kind of authorization. I don't want to be a person that just on my own decides to send the manuscript to somebody else. So there has to be somebody who has to.
If I might just interject, and just in the interest of time, that's the beauty of the APA. Perhaps offline, you might be able to find people, and certainly it's been in the news, and it's very, very important to look at the epidemiology.
It looks like it was done, the actual data was collected in 2019, sometime probably in the last 2 quarters.
Thank you. The last, we'll have one question. Yes, one question, please.
The recent study shows that opioid use increases the incidence of COVID-19. Any of your 3% patients were on opioids or that developed pancreatitis?
I don't know. I don't think so. In our series, we don't find any patients having had opioid-induced pancreatitis.
Marty, once again, thank you for presenting. So you mentioned in your slide that there was less alcoholic pancreatitis, less alcohol in your cohort, which is a little bit surprising. My anecdotal evidence is that every time I went during COVID to Total Wines, there was a lot longer lines there. and my wife Manju tells me that I drank a lot more wine during my stay at home in COVID. So I don't know. I just wanted to make a comment, but thank you very much.
That's why I said I was surprised. But again, this is the cohort of patients with pancreatitis. And in both of those brief communications, as you know, in gastroenterology, there was significantly lower prevalence of alcohol use in the COVID patients than in the matched controls without COVID who had pancreatitis. So it suggests that it's being washed out by maybe a cause effect or something else. I don't know if the others agree.
I think it was less in India. I understand, Pramod, that they shut down all the liquor stores during COVID in Delhi.
That's right.
Thank you. I think this
But
conversation.
the first thing they opened was liquor shops.
So that conversation will continue at a bar. Thank you to the presenters. I'm sorry if you wanted to say something. It was difficult to know who wanted to say what, but I really appreciate the presenters who are on with us remotely as well as with us. And on behalf of Dr. Krishnan, I'd also like to say that it seems like the pancreas, as we end, is really a model organ for many things, including our understanding of COVID. And as we think about news, for example, recent news from yesterday about Pfizer's drug, about Merck's drug that's coming out, ways to mitigate severity for a wider number of people, it's really, I think, a contribution to think about the stuff you've heard today, including on lipids and in pancreatitis. And with that, I'd like to close the session and thank the presenters with a round of applause.